In terms of the patients, we always get asked a lot about the medications. What are
Yeah.
the protocols for medications, for the disbursement of medications, for someone, one, who is diagnosed with PAD? Here, you're told depending on their situation, aspirin and a statin, maybe a blood pressure drug, and then after a procedure, they might get, let's say, Plavix or Brilinta and or Xarelto or Eliquis. What's the protocol there?
Yeah, so that's true. So most patients, when they're diagnosed with PAD, will be started on a statin and aggressive blood pressure control, risk factor modification. So we get them to stop smoking, make sure their diabetes is being properly managed if they've got that as well. If they have a procedure, then generally I'll put them on clopidogrel and aspirin, dual antiplatelets for maybe 3 months, depending on exactly what lesion we're treating. If it's a recurrent problem, particularly if there's a thrombosis that's occurred, like a clot has happened, I might put them on a DOAC, so Eliquis or Xarelto, instead of the clopidogrel or instead of the aspirin. We also have a small subset of patients where if they've got PAD and they've got severe coronary disease, and I think they have to have diabetes as well from memory, they will actually qualify for Xarelto, low-dose Xarelto treatment. So that's coming off the back of the Compass PAD results. I have a few patients where we've got them on long-term low-dose Xarelto. The caveat in Australia is that has to be a multidisciplinary decision. So unfortunately, they need a vascular surgeon and their cardiologist and their GP all agreeing that that should be the treatment for them. So it's not as straightforward as just giving a script for clopidogrel or aspirin or even a statin. It is a bit more complicated, but I think we'll find that those barriers will come down in time for low-dose DOAC. Yeah.